السلام عليكم ورحمة الله وبركاته. مرحبا بطلبة المرحلة الثالثة. This is a lecture on the presenting symptoms in respiratory diseases. What's meant by presenting symptoms? It means what are the symptoms which are predominantly present in patients who have respiratory diseases. It's also called the cardinal symptoms of respiratory diseases. If a patient has respiratory disease, how would he present to his physician? He is most likely to have cough, sputum, HAEMOPTYSIS, chest pain, dyspnea, or what's called also breathlessness, or wheezing. So one or combination of these symptoms are the way that these patients present to their physicians. These are called the presenting symptoms. So the diseases are shown as cough, sputum, HAEMOPTYSIS, chest pain, breathlessness, wheezing in variable combination. The most important of these is cough and sputum. Cough and sputum. This is both together. Cough and without sputum is the most frequent symptom of respiratory disease. Cough is normal, and every person, even if he is not diseased, may cough. And cough is a normal protective mechanism that ensures the removal of the mucus and foreign particles from the airways. Without cough, mucus will accumulate, foreign particles will go down to the lung, and the cough is a protective mechanism to clear the secretion, to clear the airways from foreign particles, from excessive secretions. Impairment of cough reflex is harmful and exposes the patient to risk of diseases, and is particularly the risk of aspiration of his oropharyngeal secretions to the lower airways, and makes patients without effective cough at risk of aspiration pneumonia. Cough due to that's also aspiration pneumonia, that's inflammation of the lung caused by aspiration of substances of secretions from the upper airways. Cough due to disease, however, is persistent and excessive. If patient continues to cough, he is not healthy, he should also have a disease. So the cough, when it is very persistent and very excessive, this is abnormal. Just before describing the abnormal cough, just want to know how does cough occurs. How does cough occur? Cough starts with deep inspiration. This is before the cough. This is the nasopharynx, the oropharynx. This is the trachea, and this is the lung, and this is the diaphragm. So some irritation here has started cough. So cough starts with deep inspiration, followed by strong expiration. So it starts with deep inspiration. How deep inspiration occurs? When the diaphragm draws down and the intercostal muscles expand the chest, so the lung will be full of air. This is inspiration. Deep inspiration initiates the cough. So initially, patient takes deep breath. This is followed by strong expiration. Strong expiration with the diaphragm suddenly elevated up, and the intercostal back to their size, inducing expiration, which is strong. However, expiration would be against closed epiglottis. That's closed larynx. So there is a high pressure resulting from this strong expiration, and the glottis, the larynx, is obstructed, is closed. Then all suddenly the larynx would open. Such sudden opening of the larynx would result in explosive flow of air. This explosive flow of air helps in removing these secretions here in the airways, for example, accumulating here in the trachea, and together with the foreign particles. So it starts with the secretion of something that induces the cough. Here the secretions results in deep inspiration to fill the lung, then forceful expiration against the closed glottis. Then all of a sudden the glottis opens, resulting in a forcible explosive flow of air and getting rid of secretions and all particles out to be expelled. This is followed by restoration of inspiration. So these are the phases of normal cough. If these explosive components of cough is lost. It can occur because of respiratory muscle paralysis. If the patient cannot produce strong expiration because of paralysis of the respiratory muscles, then the explosive nature of the last step of the explosive phase of cough would be lost. Also, if the vocal cords are paralyzed, so he would not be able to close the glottis efficiently, and so it would keep open, or will not be compressed at the site of, not be closed at the site of at the stage of compression, and so there will be no explosive nature of the last phase. So loss of explosive component of cough occurs in respiratory muscle paralysis and in vocal cord palsy. First, because he cannot induce sufficient expiration, and vocal cord palsy because he cannot close the glottis efficiently. When the vocal cords are paralyzed, he will not be able to keep them near each other to close the glottis. Paralysis of the vocal cord, apart from reducing the explosive nature of the cough, also makes the cough prolonged and low-pitched and inefficient. We call it bovine cough. It's not like oh. That's, you cannot make the strong cough. You cannot close the vocal cords, so the cough would not only lose the explosive component, it would make it prolonged, low-pitched, and inefficient, so-called bovine cough, because it becomes similar to the sound of the voice of cows. Commonly associated with what? With hoarse voice, because the problem is in the vocal cord, and the vocal cord are responsible for production of voice, so there's also hoarse voice. For patients with the problem in the vocal cord, when the vocal cord are paralyzed, the cough would be bovine-like, with loss of explosive nature, commonly also associated with hoarse voice. This hoarse voice, together with these features of the cough, indicates that the problem in the larynx. For example, case of vocal cord palsy, and we're talking about vocal cord palsy, which causes the bovine cough, the hoarse voice, the problem with the vocal cord, like vocal cord palsy, that associated with the loss of explosive nature of the cough, and results in this bovine type of cough. Hoarse voice all occur in all diseases of the vocal cord, not necessarily paralysis of the vocal cord. What are the causes of cough? The cough results from irritation of receptors present in the airways or in the lung parenchyma. These sensory nerves may be present in the pharynx or in the larynx, in the trachea, in the main bronchi, in the lung parenchyma, and sometimes just these are side effects of certain drugs. So if there is something in the pharynx, there is secretions collecting in the pharynx because of postnasal discharge in case of rhinitis and sinusitis, presence of secretions coming from the nose in case of rhinitis, or from the sinuses in case of sinusitis, dripping back to the pharynx will irritate the pharynx, and this will induce cough. And this is one of the common cause of cough, acutely, for example, in case of acute rhinitis, zukam, or case of sinusitis, the patient coughs because of secretions coming back from the sinuses to the pharynx, or something chronic like chronic sinusitis, postnatal discharge. So the pharynx is one of the important sources for the sites of cough. So diseases of the pharynx, particularly postnatal discharge, goes with the dripping of secretions from the sinus or from the sinuses or from the nose back to the pharynx, would irritate the pharynx, inducing cough. The cough may come from the larynx. This is in case of whooping cough, pertussis, where there is a laryngeal spasm with the respiratory hoop, giving the cough particular features characterized by episodic coughing together with a respiratory hoop, which is for which the disease was called whooping cough. صوت حديق, occurring with the cough. Laryngitis, an inflammation of the larynx, a laryngeal tumor, are other causes of laryngeal diseases that induce cough. If there is associated vocal cord palsy, the cough would also be associated with the loss of explosive nature and would be bovine-like. Cough coming from the trachea occurs in conditions like tracheitis, tracheal inflammation of the trachea. When there's cough because of problem with disease, the inflammation of the trachea. In the bronchi, acute bronchitis or not a short history of cough because of inflammation of the bronchi, or in case of a chronic obstructive pulmonary disease, it's a chronic disease of the airways occurring in those who are common in the long-standing smokers. Chronic cough, the source of cough are the bronchi. In asthma, also the bronchi is responsible, and bronchial carcinoma tumor of the bronchi. So acute bronchitis with acute process, or chronic like COPD, chronic obstructive pulmonary disease, asthma, and some serious disease like bronchial carcinoma, all would produce cough. Laryngeal lung parenchyma may be the source of cough. For example, in case of infection of the lung parenchyma, pneumonia, or tuberculosis, which also involve the lung parenchyma. When I say parenchyma, I mean not the bronchi, but the lung tissue itself. So pneumonia with inflammation of the lung parenchyma, infection causing inflammation of the lung parenchyma, that's rare. Tuberculosis, with also disease, predominantly involve the lung parenchyma. Bronchiectasis, bronchiectasis should be put above. Bronchiectasis is a disease of the bronchi with dilatation of the bronchi, so it's not of the lung parenchyma, it's of the bronchi. So pneumonia, tuberculosis, pulmonary edema, in case of heart failure with the congestion and transudation and fluid filling the alveoli, pulmonary fibrosis, the group of diseases with fibrosis of the lung, predominantly at the alveolar level. All these may produce cough, and the cough here that is caused by disease of the lung parenchyma. The cough may sometimes be a manifestation of disease of drugs side effects. Angiotensin converting enzyme inhibitors are the usual culprits. Angiotensin converting enzyme inhibitors, these are group of drugs used as antihypertensive, used in heart failure. The main side effect is cough, occur about 15-20% of patients. So any patient with a chronic cough, ask about use of drugs to exclude angiotensin converting enzyme inhibitor induced cough. So the site of cough may be a disease in the pharynx. The cause of cough may be disease in the pharynx, in the larynx, in the trachea, in the bronchi, in the lung parenchyma, and can be sometimes a side effect of a drug. How to differentiate between these? If the cough is from the larynx, in case of laryngitis, in case of laryngeal carcinoma, in case of whooping cough, then you expect hoarse of voice. Hoarse of voice, however, is not present in whooping cough, but hoarse of voice is present in case of laryngeal carcinoma, acute laryngitis. Hoarse of voice means صوت تغيير الصوت إلى بح صوت مبحوح. So if there is cough with hoarse of voice, it means that the cough is originating from the larynx. Why? Because there are vocal cords in the larynx, and the vocal cords involved by inflammatory process or by malignant disease. Certainly you expect change in the voice because the vocal cords are responsible for production of voice. So diseases of the larynx, which also involves the vocal cord, will produce cough associated with hoarse of voice. In these patients also, we expect that the cough is painful. Painful cough also characteristically occur in case of laryngeal disease. One of the features of laryngeal disease is occurrence of cough as paroxysms, attacks. This is particularly a feature of pertussis whooping cough, with cough occurs in paroxysms, in attacks of cough. Association with stridor. Stridor is an respiratory sound caused by narrowing of the upper airways. Here, narrowing of the larynx. If there's, for example, tumor of the larynx that causes the cough would maybe associated with hoarse of voice, and commonly also associated with stridor. Stridor is a sound heard during inspiration. Is caused by obstruction, narrowing of the upper airways at the larynx or the trachea. Like this. This sound is called stridor because of obstruction of the upper airways. And as I told you earlier, bovine cough is a feature of laryngeal disease when there is also a vocal cord palsy. In case of paralysis of the vocal cords, which is, the cough would also change in character. It loses its explosive nature, becomes prolonged, low-pitched, and inefficient, just like the sound of cows with bovine cough. So what are the clues? علامات which suggests that the cough is caused by disease of the larynx. It being painful and occurring in paroxysm, association with hoarseness of voice, the presence of associated stridor, or the presence of bovine cough. Any of these, especially hoarseness of voice, stridor, and bovine cough, would mean that the problem is in the larynx, and the cough is coming from the larynx. Being painful, occurring in paroxysms, are other less specific features of diseases of the larynx that can cause cough. If the cough comes from the trachea, that's in case of tracheitis, the pain is raw retrosternal. There is also associated with the cough that is raw retrosternal pain. That's when the patient coughs. At the time of cough, during each cough episode, the patient gets pain behind the sternum, called retrosternum. Why? Because the trachea is located behind the sternum. It's described as raw, كأنه مجرح, مؤلم. And so with each cough, the patient feels pain in his chest, just like this patient is doing. Because it hurts him, he touches his chest at the center with the site of pain occurring during cough. لما يقح يحس بألم يجرح صدره بالنص. This because the cough is coming from is caused by disease of the trachea, usually tracheitis, inflammation of the trachea. It coming in association with the bronchitis, does not usually occur alone. Trachea is called tracheobronchitis. What characterizes that is during the cough, patient has a central retrosternal chest pain with each cough. During the cough, just felt like row-like. That's painful, irritating, just like كأنه مجرح صدره، الألم تتجرح بصدره. This is called raw retrosternal pain. Cough of asthma, it has certain features. It is usually dry, but may be productive of mucoid or sticky sputum. It's characteristically worse in the early morning. The patient says that I'm worse with the most prominent cough early in the morning. It may also be present at night, called nocturnal cough. Or the cough of asthma may worsen in exposure irritants مثل الدخان, تراب, عطور, سجاير. All irritates. These irritants may also worsen the cough of asthma. A very important point to say that the cough is because of asthma is the presence of dyspnea and wheezing together with the cough. The patient has dyspnea, breathlessness, together with wheezing, صوت الوسوسة أو الصدر, wheezing. The presence of these features together with the cough would strongly suggest that this is asthma. Also, the cough of asthma occurring in attacks, not spread all the time, associated with early morning worsening. It may occur at night. It worsens with exposure to irritants. It may sometimes induced by exercise. It can be dry, but can be productive of little mucoid or sticky lesage sputum. Dyspnea and wheezing associated with cough is a strong point to suggest that this is asthma, although some patients with asthma would present with cough alone. Patient with chronic bronchitis, chronic bronchitis, which is part of COPD, part of the chronic obstructive pulmonary disease. The disease called COPD, chronic obstructive pulmonary disease, has two components, chronic bronchitis and emphysema. The disease is caused predominantly by smoking, by long-standing smoking. The cough of the chronic bronchitis, which is responsible for the cough in patients with COPD, can be dry or can be productive. Mucoid, purulent according to the situations, and without infection, it's usually mucoid, but with spread infection will become mucopurulent, يعني أخضر. Worse in the morning. This is also similar to the cough of asthma. It's also worse in the morning, and the patient continues to cough until expectorating sputum. When it expectorates, it gets better. Cough of lung cancer, which is something serious, is persistent. It's present all the day and night. Often associated with HAEMOPTYSIS, blood in the sputum, in a patient with persistent cough, of duration of weeks, for example, or months, who has been a smoker, should strongly suggest lung cancer. HAEMOPTYSIS, that means blood in the sputum. Cough of tuberculosis is present subacutely or within weeks or within months. Productive of purulent sputum. purulent, that contains purulent from pus, that's become nearly yellowish or greenish. And so cough from sputum is productive most of the time rather than dry, and sputum is purulent, commonly with haemoptysis. Haemoptysis is a point with a symptom commonly occurs in tuberculosis. There's also fever, malaise, maybe weight loss, other features characteristic of tuberculosis, which is still. Cough of bronchiectasis. Bronchiectasis is associated with, which is permanent dilatation of the bronchi, is associated with copious sputum. Copious is large amount of sputum. The largest amount of sputum is produced in patients with bronchiectasis. So the bronchiectasis is a chronic disease, so patients present with long-standing cough, commonly years rather than months, years. Mostly purulent. Most of the time, sputum is copious, large amount, and also purulent, and it may be induced by changing posture when he changes from the left, especially at night, from changing from the left to the right. In this change in posture, the drainage of secretion and cough may be induced. There may be haemoptysis, as common, intermittent haemoptysis, most of the time mild, but sometimes massive. Cough of acute pulmonary edema. During acute pulmonary edema is a serious situation in which there is worsening of heart failure and accumulation of fluid in the lung, and alveolar edema. Acute pulmonary edema is associated with severe dyspnea. There is also cough, and the cough occurs with the dyspnea. Dyspnea is predominant, and cough of a little minor importance. And the patient may produce sputum which is frothy sputum, sometimes blood stains. These characteristic features, when you come to analyze this cough, these points should be asked about, and may make the analysis easier, and you can understand that cough is probably from the larynx when he talks about hoarse of voice occurring with stridor, bovine cough. With the intestinal chest, with the cough, may think of tracheitis. When it is on immediately at night, it is worsened by irritant, may think of asthma. Especially there is wheezing and dyspnea. If this is a heavy smoker, having dry or productive coughs in the morning, may think of chronic bronchitis. When it would persist for over weeks with haemoptysis, think of lung cancer. When it's fever, purulent sputum, and haemoptysis, think of tuberculosis. When it's copious, purulent, and think of bronchiectasis. When it's associated with severe dyspnea and frothy sputum within a short period, think of pulmonary edema. This is how we analyze the cough, to try to know what is the source, what is the cause of cough, because there's a very long list of causes of cough, and it can come from anywhere, from the pharynx down to the lung parenchyma. There are certain patients who present with a sort of form of cough called the chronic cough. Chronic cough is unproductive cough lasting for more than 8 weeks in the presence of normal chest X-ray and spirometry. So a patient who comes with cough only for 8 weeks, and there's no clear cause, taking chest X-ray is normal, making spirometry, which is the pulmonary function test, and it's also normal. It's called chronic cough. What can be the cause of the chronic cough? The patient who presents with prolonged cough without clear cause, without clear associated symptoms, and the X-ray is normal, and to exclude, for example, lung cancer, bronchiectasis, pulmonary fibrosis, pulmonary edema, etc. And spirometry is normal, making the diagnosis of asthma not straightforward, not of chronic bronchitis, which should show changes in the pulmonary function. In these patients, what can be the cause? Most of the time, this is caused by one of the first three: postnasal discharge, cough variant asthma, and gastroesophageal reflux disease. This is called the triad of the chronic cough, ثلاثية السعال المزمن. Postnasal discharge, the secretions coming from the nose, the sinuses, coming back to drip posteriorly to the postnasal space, to the base and the pharynx, is called postnasal discharge. Postnasal discharge irritates the pharynx, causing cough, which is chronic. This can be secondary to rhinosinusitis of different types. Some are allergic, sometimes chronic sinusitis with polyposis, some cause vasomotor rhinitis, etc. It's a long list of causes of this rhinosinusitis, with categorization, all those with result in postnasal discharge. We say easily, simply, the most common cause of chronic cough is postnasal discharge. Another cause is chronic cough variant asthma. That's asthma which will present as cough predominantly. So cough variant asthma, where cough is the principal, that is the main or the exclusive, the only manifestation of asthma in these patients, because the absence of clear dyspnea and wheezing, the diagnosis of asthma may become late, and the patient comes patient comes with a long history of cough and diagnosis is not clear. Gastroesophageal reflux disease, where there is reflux of stomach contents up to the esophagus, resulting in aspiration and cough. This is a third important cause of chronic cough. Always think of ACE inhibitor that they are responsible for chronic cough without finding clear cause. This can occur in up to 10 to 15 or probably 20% of patients receiving ACE inhibitors. For any patient receiving captopril, lisinopril, enalapril, it ends with pril, who also has chronic cough, the first thing to do is to stop this medication and to change it to another antihypertensive or antiplatelet medication, because they are likely to be responsible for the cough. Whooping cough, the telepertussis infection, called pertussis. This is also an important cause of chronic cough that may last up to 3 months, but not longer. And should be all considered when there is some epidemiological reason to think of it. For example, contact with a child with a chronic cough or persistent cough, and this is the fifth important cause of chronic cough. What's hemoptysis? Hemoptysis is coughing up blood, irrespective of its amount. However, little or excessive, any expectoration, coughing up of blood is called hemoptysis. يعني سعال نفث دموي. And the patient يقح دم. It's not hematemesis when the patient vomits blood. Here, hemoptysis. The difference between hemoptysis and hematemesis is that in hemoptysis the blood is seen clearly as red color. When hematemesis it changes to coffee ground. And in case of hematemesis, the patient also has melena, which is black stool most of the time. In hematemesis, the patient may have food particles together with the blood to ensure that it's coming from the stomach. Here, in case of hemoptysis, you may see sputum or froth, indicating that the origin is from the lung rather than from the stomach, from the GIT. However, the differentiation between hemoptysis and hematemesis may be difficult unless you take a very careful history from the patient to know whether he is talking about hemoptysis, coughing of blood, or he's talking about hematemesis, which is vomiting of altered blood. It is, however, a serious and alarming symptom to the patient. It is serious many times, and it is alarming, and it should be alarming to the patient, خوف المريض, and should always be considered seriously. It should be differentiated from hematemesis, with vomiting of blood, and also from bleeding from the gum, from the nose, called nosebleed or epistaxis, because it can cause a lot of confusion. The bleeding from the mouth, from the gums, for example, the patient may spit blood rather than coughs blood. يدفل دم ما يقح دم. If the patient is bleeding from the epistaxis, he may also spit blood, because bleeding in the nose may go back to the postnasal space and it becomes available in the mouth and be spitted. So always check the nose whether there is also bleeding from the nose. These are important points to differentiate from hematemesis and from epistaxis or from gum bleed. In epistaxis and gum bleed, the blood is frank blood, but in both of them the patient does not cough blood; he spits blood. In case of vomiting blood, it's called hematemesis, and the blood they use is sputum, and the blood is altered, coffee ground like. What can cause cough? It can be lung cancer, which is the most serious. It can be tuberculosis, which is also an important disease. Bronchiectasis, it's one of the common causes of hemoptysis. Pulmonary embolism, a serious cause of hemoptysis. That's embolization of thrombotic material from the leg veins to the lung. Acute bronchitis is the simplest of all these. It's common, but always make sure it's not other condition. If no other cause is found, and the problem has occurred within a short period and then resolved, just say it's acute bronchitis, irritation of the bronchi, bronchial mucosa resulting in hemoptysis. Pneumonia, it can also be responsible for hemoptysis. These are the major causes, but a long list of other causes much less common. How would you analyze the hemoptysis? How would you know from the history, or try to know from the history what is the cause? A history of repeated small hemoptysis or blood streaking of sputum is highly suggestive of lung cancer. The patient tells you that over the last few weeks, last few days, he sees blood, little amount, in streaking مثل الخطوط in his sputum, or if a little amount of blood is seen each time within those last period. He says, I noticed blood today. It was present 3 days ago, 1 week ago, but not within the last 3 weeks, 4 weeks, but not before that. Especially in those who are smokers, this is very, very suggestive of lung cancer. So instead of repeated متكررة, small hemoptysis or small hemoptysis, or sometimes only blood streaking خطوط من الدم of sputum, is highly suggestive of lung cancer, particularly smokers. Hemoptysis in association with fever suggests an infectious cause. Hemoptysis together with fever suggesting infection. For example, acute fever and hemoptysis, fever in short period, and hemoptysis, think of pneumonia, or if the X is normal, acute bronchitis. خلال أيام فقط, high fever together with hemoptysis, with cough and hemoptysis, think of infection, acute infection like pneumonia, which is pulmonary infection of the lung, acute bronchitis, the trachea. They would be differentiated on the basis of the X-ray. The X-ray is abnormal in pneumonia, with normal in acute bronchitis. Hemoptysis in a patient with longer history of fever, not acute fever within days, but long history of fever, for example, weeks, associated with weight loss, with night sweating. This would suggest tuberculosis. Also lung cancer to less extent, but predominantly suggests tuberculosis. So both pneumonia and tuberculosis, there is fever, but the fever of pneumonia takes short period, while that of tuberculosis takes longer period of weeks to months, with weight loss, night sweat, etc. Lung abscess may present with similar symptoms to tuberculosis, and it's also a cause of hemoptysis. Coughing frank blood without associated sputum, blood alone without sputum, suggests vascular cause, like what? Like pulmonary embolism, or bleeding disorders like leukemias, or because of overdose of anticoagulants drugs. So coughing blood, when the patients say that I cough blood alone without sputum in it, think of the problem in the vessels, like pulmonary embolism, where there's infarction of the lung caused by thrombus coming from the leg veins up to the right atrium, to the right ventricle, the pulmonary artery, and then to the lungs. This is pulmonary embolism. It's a serious situation. It can cause blood alone, or from bleeding disorders of excess bleeding tendency. With all the bleeding tendency would not present with hemoptysis at the time, but sometimes present like this. Another point is chest pain, another symptom. We talked about cough and sputum. We talked about hemoptysis, which is the blood in the sputum. Chest pain. What's chest pain? Chest pain, pain in the chest. Pain in the chest can be caused by respiratory disease or by cardiac disease. Sometimes also by esophagitis or musculoskeletal. However, respiratory causes of chest pain are usually peripheral, usually not central, on the periphery of the lung, that's on the lateral, on the right side, rather than in the central. Central chest pain that's central, that's retrosternal, behind the sternum, is most often a manifestation of heart disease. So pain who touches the center of the chest, you complain of pain, this pain is most likely to be coming from the heart. However, it can be coming from the esophageal disease, so like reflux-esophagitis, gastroesophageal reflux disease. It can occur because of aortic dissection. It's a serious situation where there is rupture of the intima with the blood tracking along the media, causing false tract within the wall of the artery. This is called aortic dissection. It also can cause severe pain in the center or primarily to the back. Respiratory causes of central chest pain is massive pulmonary embolism. Pulmonary embolism is massive, that's large amount, big thrombus obstructing a major pulmonary artery. In case of tracheitis, I just described, the patient has chest pain during cough, which is raw pain in case of tracheitis, or mediastinal tumor in the mediastinum, for example, in case of lymphoma, thymoma, germ cell tumor. These tumors that are not in the mediastinum, it's also in the center. So, although most of the central chest pain is caused by heart disease, however, it can be caused by esophageal disease, aortic dissection, or by respiratory diseases like massive pulmonary embolism, tracheitis, and mediastinal tumors. What are the respiratory causes of chest pain in general? These can be pleurisy, which is the most important respiratory cause of chest pain. Pleurisy is a sharp had, peripheral, that's not central, of the periphery of the chest, peripheral chest pain, aggravated by deep breathing. It's important. Sharp peripheral chest pain, aggravated by deep breathing. When the patient takes deep breath, the pain worsens, or cough originates So this is a description of pleuritic chest pain: sharp, peripheral chest pain aggravated by deep breathing. This means that the cough originates in the pleura. What can be the cause of this pleuritic chest pain? Pleural infection of the pleura, or pleural infarction, or malignant infiltration of the pleura. So the patient has some problem here in the pleura overlying the lung. The pleural pain, which induces this type of description of pain, is called pleuritic pain or pleurisy. However, it has multiple causes: infection of the pleura, infarction of the pleura, or malignant infiltration of the pleura. Anyhow, the patient would have pain at the periphery of the chest that worsens by deep breathing, worsens by coughing. The patient may keep his chest hand on the chest during breathing, during coughing, to avoid worsening the pain. This is because of inflammation, infarction, or infiltration of the pleura. This is called pleurisy, pleuritic chest pain. Pleural infection is commonly the cause. This is caused by pneumonia. When there is inflammation of the underlying lung, the pleura can be walled by the inflammation, resulting in this pleuritic pain. Or lung abscess, also abscess near the chest wall. The abscess, that's collection of pus within the lung, may also induce similar infective changes in the pleura. Or tuberculosis, when the pleura is involved by the tuberculosis process. All these are causes of pleural infection that causes pleurisy and pleuritic chest pain. Pleural infarction, the problem may not be infection, but infarction of the underlying lung. In case of pulmonary embolism, the infarcted lung with the overlying pleura would be also involved by the infarction, producing the pain. Malignant infiltration of the pleura, in case of lung cancer. Lung cancer infiltrating the pleura or causing pleural effusion may also produce the same pain. So, sometimes there is inflammation of the pleura without infection. In case of inflammatory disorders like systemic lupus erythematosus, rheumatoid arthritis, there will be also pleuritic pain. Not here because of infection, no infarction, not malignancy, but inflammation, non-infective, caused by these systemic infectious disease, systemic inflammatory disorders. So the major cause of chest pain, which is respiratory, is the pleurisy, which produces or called the pleuritic pain, with sharp, had, with khanjar, peripheral, not in the center. The patient says that it's aggravated by deep breathing, aggravated by cough. The cough here originates at this strong tone, or it's not right. Just to say the cough here originates from the pleura. Tracheitis is another example of chest pain from respiratory origin. Here the pain would be center rather than peripheral. And it's described the chest pain of tracheitis, which is raw pain, retrosternal, induced by the cough. Usually tracheitis is acute process that develops over days, no more, due to the bronchitis. Massive pulmonary embolism may also cause chest pain, but which is central rather than peripheral. In the case of pulmonary embolism, which is not massive, it results in pulmonary infarction and pleuritic chest pain. But a big thrombus would obstruct a major pulmonary artery, causing central chest pain, severe central chest pain, just like the pain of ischemia, of cardiac cause. Acutely severe central chest pain with severe dyspnea and commonly with hypotension. Musculoskeletal chest pain, because of problems in the muscles or the bones, would be aggravated by movement and would be associated with local tenderness. It's a common cause of chest pain, caused by example by injury, by sports, by trauma, by exposure to cold weather, by excessive exercises that can produce pain in the chest, usually worsened by movement, generally by deep breathing. There's also local tenderness according to the site. Malignant infiltration of the chest wall, not the pleura, the chest wall, and ribs can cause mowing, مثل القرف يقرض الألم كان يقرض الصدر, drawing continuous local pain. Where the most severe chest pain occur in this condition of malignant infiltration of the chest wall and the ribs, commonly by lung cancer, but also by other metastatic malignant disease. So these are the descriptions of possible causes of chest pain due to respiratory rather than other causes of chest pain. However, the chest pain can be central and caused by cardiac causes. For example, myocardial infarction, a stable angina pectoris, or myocardial infarction. It can be caused by dissection of the aorta. And it can be caused by esophageal disease, reflux esophagitis, as an important example. Dyspnea is feeling of uncomfortable need to breathe. The patient feels that he has to take a breath because he feels sufficiently comfortable from his breath. So feeling of uncomfortable غير مريح, need to breathe, شعور غير مريح بحاجة إلى النفس. This is called dyspnea. This can be physiological during exercise. Anybody who exercises to a limit, he would feel the sneak. This is normal physiological, but maybe pathological. Pathological when it is due to disease. Most of the time the disease is in the lung, but can also be in the heart. So heart failure would also cause dyspnea. But majority of causes are respiratory, because what is responsible for breathing, this is the lung. So patients with dyspnea, however, may present with chronic exertional dyspnea. So patients with respiratory disease, or in general dyspnea, can be chronic exertional. The patient has dyspnea all the time, that is worsened by exertion to certain limits. For example, some patients may tell us that they can move on the ground, but they cannot get upstairs, or not so the dyspnea is limited by significant exercise. Some others, the dyspnea is limiting the activity, that the dyspnea even at rest, and it can be progressive. This is called exertion, chronic dyspnea, present most of the time. Some people may present in emergency with acute severe dyspnea, this serious acute severe dyspnea. So he may have chronic dyspnea, may not having dyspnea in the past, but presents with very severe dyspnea, with a life-threatening situation, then is about to die if not treated. This acute severe dyspnea. This is a medical emergency seen in the casualties. About chronic dyspnea, this chronic dyspnea, which is dyspnea was present for a long time, from months or years, which can be severe, can be mild according to the situation. Such presentation can be due to heart disease, like in case that's chronic heart failure, or to respiratory disease. An important point from the beginning is to try to differentiate whether this chronic dyspnea is cardiac or respiratory. So those patients with cardiac dyspnea, and most of the time this indicates heart failure, would have some clue to the presence of heart disease. For example, they have coronary heart disease, they have a history of angina, chronic myocardial infarction, or chronic coronary heart disease, and they may be hypertensive, may have risk factors for coronary heart disease apart from hypertension. They may be diabetic, hyperlipidemic, and they may have catheterization in the past with angiography and stenting. So there are clues in the history that they have heart disease. And another important point is that the presence of orthopnea, dyspnea, lying flat. They feel dyspnea when they lie flat, and they avoid lying flat by lying on many pillows. They may have paroxysmal nocturnal dyspnea, that they may sleep initially, but they wake in the middle of the night, usually 2 hours after sleep, because of dyspnea that makes them unable to lie flat again. They wake up from dyspnea, and then they leave the bed or go to open the door, again at the window, and they go back to sleep, and they can sleep, but maybe awaken again. So it's called paroxysmal nocturnal dyspnea. Paroxysmal occurring in paroxysmal. Nocturnal, that's at night, dyspnea. So dyspnea of breathlessness occurring at night in attacks in paroxysms is very characteristic of heart failure. So orthopnea and nocturnal dyspnea, they get it off strong features and should be always asked about. So any patient who comes with a chronic dyspnea, ask about orthopnea, ask about PND, that's nocturnal dyspnea, and ask about history of coronary heart disease, of hypertension, only clues the presence of heart disease. However, chronic dyspnea can be due to specific diseases like COPD, chronic obstructive pulmonary disease. What differentiates this dyspnea of COPD from other types of dyspnea is that the dyspnea of COPD is exertional. It occurs with exertion predominantly. It's not present at rest, except in very severe diseases. Very severe disease. The patient is breathless when he moves, when he walks, and sometimes for only a few for a few meters. Some milder cases when he gets upstairs. In milder cases, even milder with strong exertion. So the exertion, however, and depend on the severity of the case to say to which degree of exertion. So exertion على الجهد. And so the dyspnea of COPD is worsened with exertion. There is a progressive loss of exercise capacity over months and years. So over the years he's worse and worse. قبل 5 سنين مثلا يصعد درج بعدين ما يمشي ممكن يمشي على المستوى على الأرض بعدين حتى حركة مشي بداخل البيت صعب. So it is a progressive loss of exercise capacity. It's constant over days. So the COPD he has the same all the days within خلال الأيام في نفس المستوى من ضيق النفس. There's no variation, but it's progressive over time. It's less prominent overnight when he usually has comfortable sleep. But he may have orthopnea, just like patient with heart failure, but the predominant is a feature of heart failure. So chronic exertional dyspnea that's progressive over time, but constant over days. Over time, over months or years, it progresses, but over days it's just similar. And it's not very prominent at night. Probably he's best at night and has comfortable sleep. This is in contrast with patients with asthma. The asthma typically have variable degree of dyspnea within and between days. So the changes, the variations between days. A few days he is well, another day he is has quite severe symptoms. The variation of severity of dyspnea within the day and between days is characteristic, while COPD is stable over days. It's not expected to be progressive like COPD. Many patients are not distinct between the attacks, so they may have the patients COPD have this constant over days and present most of the time. Here, or all the time. Here, the dyspnea is not in asthma. The patient is not distinct between the attacks, but and he has variable degree of dyspnea. At times severe symptoms, or not. At times mild symptoms. At times no symptoms and asymptomatic. The presence of cough and wheezing are commonly present together with the dyspnea. And this is leaves another point to differentiate asthma from others. Nocturnal symptoms are common, opposite to being comfortable in case of at night in case of COPD. So he has early morning dyspnea and cough, and there may be also symptoms at night. Nocturnal symptoms of dyspnea, cough, and wheezing at night is characteristic, but it's not PND, but this worsening of symptoms of asthma at night. Pulmonary fibrosis patients, the group of diseases with fibrosis and called lung diseases, comes with fibrosis of the interstitial spaces and the alveoli. These diseases are progressively worsening with time. So there's a relentlessly progressive breathlessness, just like COPD. The problem progresses over months and years. Every year is worse than the year before. In severe conditions, this becomes present even at rest. So it's not it's present even at rest. This is more severe, very severe cases. Cough is also present, and really dry cough. It is dry cough and distressing. When I say dry, it's not productive of sputum. Some cases of dyspnea are not respiratory. Chronic respiratory dyspnea, we talked about COPD, asthma, and pulmonary fibrosis. These are respiratory diseases associated with chronic dyspnea. Chronic, that means present for over a long period. There also, we thought that dyspnea can be chronic because of heart failure. What can cause chronic dyspnea? Heart failure. And we talked about the descriptions of heart failure. What makes you think of that the dyspnea is caused by heart failure? Having history of ischemic heart disease, coronary heart disease, having hypertension, having orthopnea and PND. It can be COPD, or that the patient is a smoker with a chronic progressive dyspnea, which is worsening with time, but stable over the days, comfortable with sleep. And maybe asthma, which is variable between the days, associated with nocturnal symptoms, early morning worsening with cough and wheezing. Or it can be pulmonary fibrosis, it's a progressive dyspnea over years. At last is present even at rest, and there is dry cough. But some cases are not cardiac and not respiratory. For example, chronic dyspnea can be due to obesity. Just because he's obese, he's breathless when he moves, when he walks. So obesity is non-cardiac and non-respiratory cause of chronic dyspnea, or can be severe anemia. People who is markedly anemic, severely anemic, are breathless on activity. They don't have heart or lung disease, but they have anemia with reduced blood carrying capacity of the blood, so they are also breathless. Acute severe dyspnea. Situations where dyspnea is very severe and life-threatening. The patient may die because of dyspnea if not treated. These are important group of diseases. We need to taking detail when we talk about each of them during the fourth year courses. These are acute severe asthma. Patient with asthma present with acute exacerbation, called acute severe asthma. Asthma is a cause of chronic dyspnea, but the patient may present with worsening exacerbations, called acute severe dyspnea, which can be life-threatening. COPD may present also with acute exacerbation of their COPD, which is also life-threatening. Acute pulmonary embolism is already an acute disease, sometimes causing severe acute dyspnea. Acute pulmonary edema is acute severe left heart failure, where there is severe dyspnea because of worsening heart failure and accumulation of fluid in the lung. Pneumothorax, where there is air in the pleural space with collapse of the lung, and this is an emergency case of severe dyspnea. Severe pneumonia. Pneumonia is the infection of the lung, which involves multiple lobes in result also in severe dyspnea. Upper airway obstruction. This is something serious. Upper airway obstruction. Obstruct the upper airways because of foreign body inhalation, of edema of the larynx, in case of anaphylaxis, can cause the most serious types of dyspnea, and the patient is struggling for breath. The patient may die within a short period if not treated. The upper airway is not obstructed, or the obstruction not relieved. Acute respiratory distress syndrome, severe dyspnea caused by acute disease involving the alveoli with the exudation of protein and cellular-rich material fluid to the alveoli, complicating certain conditions. One of them is, for example, COVID-19 nowadays. Metabolic acidosis presents with severe dyspnea, but the problem is not in the lung and not in the heart. Like, for example, diabetic ketoacidosis or uremia. These diseases are the excessive production of acids, and the acid is converted to carbonic acid, and the carbonic acid is dissociated in the CO2 and water. The CO2 will be in excess, and the lung has to get rid from the CO2, excess CO2, by excessive over breathing. So the patient comes with hyperventilation, with over breathing. Why? The problem is not in the lung. The problem is in a disease like diabetic ketoacidosis, with the complication of diabetes, with excessive keto acids, and these are acids, or uremia, with accumulation of acid not excreted because of the problem in the kidney, renal failure, where the patient can't excrete excess acids, or some poisoning like aspirin, where the aspirin by itself an acid, which is these acids of the aspirin, keto acids, or the uremic toxins will accumulate in the blood, and they're converted to carbon dioxide, and the hydrogen component of them form carbonic acid, dissociated into CO2 and water. The CO2 will be present in excess in the blood, and the respiratory centers are stimulated to overbreathe, to hyperventilate, to get rid of this carbon dioxide. The patient presents with that pre-productive breathing. The problem, however, is not in the lung, but it's a metabolic disorder. Psychogenic hyperventilation. This is the easiest of them. There's no problem, but the patient is psychologically affected. So he overbreathes because of psychogenic cause. This is previously called hysterical hyperventilation. The patient breathes excessively, not because of any disease, because he's psychologically affected. He's afraid, depressed, anxious. So this presents as a casualty in the form of emergency, but it's not really an emergency. Something because he is anxious or depressed. These are all just the summarization of the conditions that may present with acute dyspnea. The details will be taken in the 4th and 6th year. Thank you.